Next is Dr. Aldo Acosta Medina, internal medicine resident at Mayo Clinic, presenting on efficacy of MEK inhibitors in Erdheim-Chester disease.
Hello, everyone. Thank you very much. As mentioned, I'm Aldo Acosta. I'm a second-year internal medicine resident here at Mayo. I would like to thank the Erdheim-Chester Disease Global Alliance for the opportunity of presenting our work on behalf of the Mayo Clinic and University of Alabama at Birmingham Histiocytic Working Group. So as means of a very brief background that has been touched by most of our colleagues here, as you know, Erdheim-Chester is a very rare and heterogeneous disorder known to be driven by mutations in the MAP kinase pathway. Particularly, BRAF V600E has been identified in up to 60% of adult patients, hence BRAF inhibitors being used as the first targeted therapy within these disorders. However, even amongst those patients with the mutation, response is not universal, hence leading to additional evaluation and research by some of our colleagues here present, ultimately leading to the use of MEK inhibitors in BRAF V600E negative histiocytic neoplasms with the approval of cobimetinib last year by the FDA for these groups of disorders. In this setting, we aim to describe the characteristics and the outcomes of one of the largest cohorts of ECD patients treated with MEK inhibitors outside of the setting of clinical trials. For this, we included all patients with Erdheim-Chester disease treated with a MEK inhibitor, be it cobimetinib, trametinib, or binimetinib at the Mayo Clinic between 2019 and 2021. Regarding tumor MEK kinase pathway mutation status, this was mainly determined via next-generation sequencing through commercial assays. However, if unavailable, this was also determined via immunohistochemistry for the VE1 clone or with allele-specific PCR to determine BRAF-specific mutation status. With regards to response assessments, this was based on the established PET response criteria used for clinical trials of targeted therapies in histiocytosis, and a survival analysis was carried out with classical methods via survival curve construction via the classic Kaplan-Meier method with comparison via log rank testing. Ultimately, 22 patients were included in our cohort with a median age of diagnosis of 52 years of age with a slight female predominance. As can be seen here, most patients, 18 out of the 22 patients, had next-generation sequencing performed, with most other patients having immunohistochemistry or allele-specific PCR. Within these 22 patients, 5 patients had no variants identified with these studies. However, we will have a little bit more of a discussion of the pathogenics identified in one of the pathogenic variants identified in one of the subsequent slides. Ultimately, 15 patients had a MEK inhibitor initiated as first-line therapy, which was mainly cobimetinib, as can be seen down here in the table to your left. The remaining patients had sequential exposures of 2 MEK inhibitors, including a cobimetinib trametinib, as detailed below, or in one case, a patient that had 2 instances of cobimetinib initiation with a cobimetinib rechallenge after patient progression. Median time on a MEK inhibitor during our cohort was 7.1 months. Delving a little bit more deeply into the genetic profile of our patients, we had, as detailed before, 22 patients. Of these 22 patients, 4 patients detailed here by our red arrows did not have next-generation sequencing performed, with the exception of patient 2, who through immunohistochemistry had BRAF V600E mutation detected. Hence, the remaining 3 patients were known not to have either a known BRAF or MAP kinase mutation and did not have sufficient genetic evaluation to consider them MAP kinase pathway wild type. Ultimately, of the remaining patients, 2 did not have a pathogenic variant identified by NGS, and ultimately 3 additional patients had non-MAPK kinase pathway mutations identified, with patient 1 identifying a FLT3 mutation and 2 patients having originally variants of undetermined significance on CSF1R, patients 6 and 20 over here, that were subsequently reanalyzed by our study group and were determined to be of pathogenic relevance and pathogenic variants. As such, within all of our cohort, these 3 patients, patients that did not have any sufficient genetic analysis were not included in subsequent survival analysis that will be detailed in next slides. And the remaining 5 patients that I have detailed below were included in what we designated our non-MAP kinase mutated group. With regards to therapy response to MEK inhibitors, after a median follow-up of 19 months, we had an objective response rate of 78.9%. Shown here, we show a swimmer's plot detailing significant events and therapy exposure to our patients. Particularly 3 points were notable that we wanted to highlight and we thought were notable of further discussion. Outlined here were the 5 patients who did not have any MAP kinase pathway mutations identified, particularly patient 14 and 8, as can be seen, did have a response to MEK inhibition. However, these 2 patients, as detailed in the slide in the previous slide, were patients that did not have a pathogenic variant identified. Then going to patient number 1, we had the patient with the FLT3 fusion. Here, as you can see, the patient progressed on top of MEK inhibition, as detailed in green, and subsequently developed a complete response that was sustained and on continued treatment with FLT3-directed therapy. A similar case was seen in both patients 6 and 20, both of which had CSF1R-directed therapy, after which they achieved complete and durable remissions. As a second point to highlight in our swimmer's plot is patient 22, who, in spite of having a MEP kinase pathway detected in the BRAF V471F, did not have a significant response with MEK inhibition in spite of 2 different trials, with only stable disease achieved after previous treatment with cytarabine. And lastly, as can be seen throughout our cohort, there were a number of patients whom, after discontinuation of MEK inhibition due to either intolerant side effects or patient request, continued to have responses to therapy, such as patient 13, patient 4, and patient 5. Progression-free survival was significantly greater in our MAP kinase mutated individuals, with a median progression-free survival of 7 months in those not carrying MAP kinase pathway mutation. Additionally, the objective response rate was also significantly greater in this subgroup of individuals. At last follow-up, all of our patients were alive and 10 patients remained on their MEK inhibitor, with the main intolerable adverse events associated with these drugs being grade 3 diarrhea, lower extremity edema, and single cases of rash pericardial effusion and dropped head syndrome. Main limitations for our study are, of course, its retrospective nature and sample size. Nevertheless, our studies highlight that MEK inhibitors are a highly efficacious treatment in patients with ECD. Additionally, we saw that treatment discontinuation due to toxicities and intolerance was common. However, this does not preclude from maintenance of tumor response for extended period in a number of our patients. And finally, and mainly, our study suggests that identification of non-MAP kinase pathogenic variants may predict ultimate response to MEK inhibition. I would like to thank the patients and families of all of our patients here at Mayo Clinic who made this research a possibility, as well as all of my mentors and co-authors and the Mayo Clinic and University of Alabama at Birmingham Histiocytosis Working Group. Additionally, my mentors here present, Dr. Go, Dr. Goyal, Dr. Abik, and Dr. Rek, appreciate your help. Thank you very much. I'll take questions if there are any.